My name is Debbie Bucci. Hi, everybody. Thank you for joining. Before I get started, is anybody here familiar with healthcare? Oh my God, here we go. So, let me go to the beginning. So, for those of you who might recognize my name, I've spent 27 years in the federal government, and I have a good understanding of the health IT space in the US government. But as the world has moved along, as COVID came along, and very much focused on health information exchange within the United States. But as COVID came along, there was a really understanding of the gap of the ability to exchange data across nations. Watching during that time, I have never seen so much raw data exchanged at the same time that you could actually, they were hospital rooms, symptoms from identified folks that with IDs that were being shared because there was such an idea, they were scrambling just to find out what were the different symptoms, whether it was a cold or not breathing, and how could you adjust it. And then I cataloged at that time, there was about, I cataloged 140 spots that had data. And with 6 months afterwards, everything is closed down. They've gone to machine learning type of things. So at one point, there was a need. They didn't know how to exchange data, and all the data was put out there. So that was a huge catalyst of, that COVID made. It made it aware. Also, during the emergency, the need to authenticate and authorize for doctors to work across borders, across states. And there was no real simplified way to do it. And they were actually using emergent technology. I put machine learning, but there's also very much telehealth became a huge, important piece in that puzzle. So about, I guess, 4 or 5 months ago, the OpenID Foundation reached out and asked if I would like to collaborate them and help them understand the health, the open health internationally, and I agreed, and then I panicked because I realized I really didn't know how things work internationally. So it was a really deep dive for me to understand. I understand within the United States what they expect to work, but how that work extends across. So there's potential and benefits about being able to do open health more broadly. The public health forewarning, the augmentation to patients' health. The other thing is it's not just clinical data. It's the idea of social determinants of health. We have so many Internet of Things. You have medical Internet of Things. You have now such things as digital therapeutics that is able to, it's software and devices that you actually can put patients on a program and track them and see how they're doing. And then consent is really, 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 really complicated. In the United States, they were saying you did not need consent for treatment payments or operations, but that's not true. You need an authorization to be for treatment. There is such a thing as the HIPAA authorization if you want to exchange data beyond which normal means. Even though they call it authorization, it's consent. And then there's also, when you go to GDPR, it's not just consent. There are other purposes of uses, so that it's authorization, permissions. There's all these different terms that you use to talk about it. And then there's a difference between fine-grained consent. There's a global consent. There is implicit consent, which is an opt-in, or implied consent. Implicit consent is you opt in. Implied consent means opt out. It's an opt out. So how do you manage that? And how do you do, as within the United States, using USCDI, how do you get to the point where patients are able to get their own information and then in turn share it? How do you apply those fine-grained consents to the actual data elements in context of how that's being given? So, and also the other thing is online protections and data privacy. It's not just GDPR. There of 137 countries that were surveyed, 130 out of 194 countries have some type of privacy. In the United States, every year there comes a legislation. They're considering having a data agency, which is outside the control of FTC. If that is the case, that may mean HIPAA might fall into that. So what we're doing, which is uniquely healthcare, may not apply in the long run as they look at data more globally. So it was time to do I did a health landscape of what was going there. And the way it works in the global, everything really goes up to the ISO. And there is the ISO Technical 215 Health Informatics. If you want to share something broadly, that is the place to do it. There is a complementarity with the CEN that through the Vienna Agreement, they keep in sync and make sure that they do not do duplicative effort, and so they try to issue standards and profiles that align with each other. HL7 is an ANSI, United States-based standards body, but there are 35 different affiliates that cover 55 different countries across the nation. And in Europe, they have an independent body that also is working with the European Union to be able to align those different standards. So if you spend time with HL7, it is really interesting when you're listening to the activities between the different implementers. And a lot of it is they're really focused on it based on their implementations that they've done. The changes are being changed in real time. They're boots on the ground trying to get things done. And then there's also the Joint Initiatives Council, which is the four above, DICOM for imaging and SNOMED, that where appropriate, they try to coordinate standards across all the bodies to have some type of uniform voice. And then other things like IETF, OpenID are mentioned, they get blessed because they're mentioned within the actual standards and profiles as it goes ahead. So this is a survey of 21 different countries about the standards that are in use today. So they are going from way back 1997, 1980s, peer-to-peer imaging and then from HL7V2 is still used very widely up to what's going up to FHIR. So they have to support SOAP, SAML, and OAuth and OpenID Connect. But these implementations have to support all of the above. So how do you, and as a result, you have as the profiles mature, as new use cases, as the treatment of medicine and innovations mature, and new use cases are identified, what happens is you're having a proliferation of different profiles because instead of necessary to see where they harmonize, they're so focused on that use case that there's a way. The infrastructure out of HL7, they do some coordinating, pretty good coordinating, but you still have different groups. An example of that in the US is there was a separate effort for the health insurance payers to be that required by CMS, that Center of Service CMS, HHS, too many acronyms, that they needed to openly share their information with their insurers, and that the focus to move to there's some open legislation about prior auth is the authorization for treatment and payment for different types of treatments that you have it be more open and value-based. So there has been coordination from Health and Human Services Office of the National Coordinator and CMS that they're coordinating standards to focus on fire. And then recently there is another legislation, Trusted Exchange Framework, and the Common Agreement, which is called TEFCA. And that is an effort to do network-to-network exchange across the United States, leveraging the health information networks that were in place. But after COVID, that is being expanded. So the work of not only leveraging for clinical information, they're also adding payer information. And then when you're looking at the ideas for research and public health, the idea of that network is the capabilities potentially is great. They expect to have they are focusing on older technology for what is in exchange for right now, which is the soap-based, and they have a roadmap for 3 years, within the next 3 years, to implement FHIR standards as well, which are RESTful-based. So, and then, of course, there is, when looking across the different nations, there is highly difference between being where one country is centralized and takes full control of the information to being more of a hybrid where they're actually have federated access for across the nation. And then there are, such in the EU, there's new legislations where they're looking at dropping the old and going straight to a decentralized environment with a focus on digital wallets. Also, there's additional legislation that recently came out that they realize that because of their open digital agenda they're going forward, that they also need to make an additional set of rules for the health environment as well. So that is how they treat it across our nations. It varies very greatly. So OpenID Foundation is focused on the identity profiles, and if you talk about global exchange, I could get really deep and talk too far. But the whole effort of this white paper, working with them, is to focus on that identity layer and what's going on. And so the IHE, the interesting thing about the IHE is they leverage existing standards. They do not create standards. So they have a draft profile, Internet User Authentication, that's going straight to OAuth 2.1 draft and using that to supplement their SAML-based exchanges that are going on right now. The HL7 Smart App launch started in 2015, right alongside the same time as the HART profiles, OIDF HART, and it recommends the use of OpenID Core, OpenID Connect Core, but it doesn't give specific guidance. Also around supporting consent, it delegates that to the implementers to figure out what to do. So within HART, HART actually started the work before SMART, focused on a totally different separate. SMART was focused on getting clinicians to exchange information, going from the document base to being able to use just individual data elements between clinicians, where the level of security did not have to be so high. The HART profiles focused on patient access and sharing of their data, and it implemented OpenID Connect and UMA, and part of those profiles include scopes that talk about sensitivity and the types of information that can be shared, or claims that based around identities about a doctor or whether they're authorized to perform like break the glass type functions. And then recently, this work, the HL7, the UDAP, was originally created for this. Does anybody know what the DIRECT project is? The DIRECT project is a implementation, I think 2015, to use secure email. And across that, they issued certificates, both for providers and for patients, to be able to securely exchange information. So what that group out of the Direct Trust, they, as things were moving towards FHIR, they took that work they did about certificates and around Direct and redirected the governance and the policies and the directions, leveraging some of the work out of HEART and looking ahead at some of the newer standards that were out to create what was called the Unified Data Access Profile. That profile is actually being the TEFCA that I talked about. The organization that is doing the implementation guides for that is referencing that. And it's also used for the payer community that I talked about before. And so each of these profiles have matured separately. They've been developed for a specific use case. And at the time, they look across the landscape and they cherry pick what is the newest and the newest, and also has to be published in standard, not a draft, to work into their implementations. And this will continue. The FHIR protocol itself is in normally, they call it version 4, but there's a number of data elements. And as the profile matures and more use cases get added, the number of data elements to go to maturity is going to take some while. US regulations is looking at 4, but some of the elements to use for payer exchange and things like that, they don't think will be mature till what they're calling version 6, which is 2026. So over the next, 4 or 5 years, there's going to be an additional, these profiles, these identity profiles will most likely mature along with the work that's going along with it. I need a clicker. Okay, and so I think many of you, hopefully, have listened to some of the work about the GAIN work that's going out of the OpenID Foundation. And this is some effort that kind of aligns with that work. There was a group of the G7, that were worried about the initiative about being able to do the cross-border exchange. And there was something called an international patient summary that they did for emergency purposes to be able to exchange within borders, mature using the CCDA format, that it was pretty mature, that has been working in Europe. It's certainly, I think it's in 15 countries, and they want to do it across 25 countries by 2024, I believe. And so it was agreed that with the maturing work of HL7, but the thing about it, across countries, data elements are different, and the type of exchanges, how it's being done. So they're looking at ways to exchange that data, maybe first focusing on Smart on FHIR, but it could be that there will be other standards that mature, especially when you're looking at EU and they're thinking about doing the wallet work. But right now they're at the CDA. So it's very much in the beginning phases. There is a work group in the HL7 called for International Patient Access that is working on that. And then there is, I didn't think I'd make it this far. And then there is a similar one going on in Europe that they're trying to collaborate across. They have successfully interop between Canada, UK, and the United States. but Japan, and then separately the EU members, France and Germany, and there's one more, they have yet to do some of the interop. So this is something to really keep an eye on. So and then here's just kind of a diagram about using the CCDA and what they're proposing to do and move it to, instead of, they're calling it a G7 IPS instead of the ISO, but it will eventually be contributed to it. So what I focused on really was the global health portion of the white paper. The piece that I didn't talk about was how the suite of profiles within the OpenID Foundation, and specifically the FAPI profiles, that are now in their second iteration after having on-the-ground, real, widespread experience, comparing those. I've done a comparison of the profiles and the standards in use in the United States and compared to the OpenID Foundation profiles, and a lot of that is aligning. And so hopefully that can be used for conversations and ways for perhaps the OpenID Foundation to help collaborate with the health community to see if there's global work going on with open banking, to see what the gap is really between using those standards for health versus using it for banking. And then I think this is my last slide. So the paper is draft, but it's live, and it's on a HEART working group workspace, and we encourage you to go out there and look at it and read and comment and give some feedback and some perspectives on some of the work. There's so many of you in here that are already working in healthcare. It would be interesting to hear what your perspectives are on that. And then if you would like to talk about it tomorrow, we're having a birds of feather gathering, and I would really appreciate if you would join me there, and so we could have discussion further. 5:58, got 2 minutes for questions. All right. Say that again?
What are the use cases for sharing medical records across borders?
Well, COVID was certainly a use case when they were trying to gather information, but also for travel. You've got U.S. citizens that are within the State Department that are in across for that. There's also what I didn't talk about is clinical trials, and to be able to have information and share. Patients have the right to have their information in the United States. In UK, they have the right to be able to view it. So there could be machine learning. There's an element about machine learning being able to go and do some analytics on it. That's another use case for that as well.
Was it vaccines that?
So the one thing I didn't talk about is, I had it in the slide, that was the other thing, the vaccine attempts that they failed. They didn't have the countries didn't have the infrastructure nor the trust to be able to move. I know later in the United States, it got pretty far down the line, and then they decided at the last minute they weren't going to do it. I believe there was a similar effort in UK. So that is the other thing, the vaccine cards, and that may feed well into the work around verified claims of the work that the OpenID Foundation is doing as well, for not only for patients and for providers as well. Yes, I don't know if I'm going to hear you.
Yeah, this user case is from the government or actually from the foundation, and you specific of this is possible user case.
Who am I speaking of about? I'm sorry, from the government?
Yeah, the user case, for example, you say.
Well, it's just that I have experience being in the U.S. government, so I understand how rules and regulations that affect health apply here. And so I was looking across globally to see where those regulations are. It's mentioned in the paper, and also how the standards are being developed and how they get blessed. That's a lot of it. And where in that work and that gap that possibly the OpenID Foundation and their standards could actually help in normalizing and improving the goal is to be interoperable across states and it's globally. And it's not just at the identity level, it's also at the data elements as well. So it's a really big task that's in flux right now.
Yeah, that's not possible. I mean, that's possible, but it's, real, like, work have done or not yet.
I'm sorry, I don't.
For the government level, they already have some interoperating infrastructure, or, you still understand what the status is right now.
Well, in the United States, there's work around mandating infrastructure that's necessary for the trusted exchange framework. And they do actually have implementations out right now, but those standards are focused very much on SOAP and SAML. But they are moving to RESTful over the next 3 years, and those guides are still being developed about what the infrastructure that would be needed for that.
So who supports the infrastructure? Like who manages the infrastructure?
The full,
Yeah.
well, that full infrastructure that's happening today, that's going globally, you can see in the IHE profiles. Those standards are being used in the white paper. You will see I have a table in the appendix that shows of the standard bodies, what countries are participating, and IHE, who does a lot of detailing the standards and doing interoperability and connect-a-thons across countries, is a place where a lot of that work happens.
Okay, thank you so much.
Yeah. Did I answer your question? I wasn't sure. Yes.
I want to make a comment also kind of responding to his question. So I'm working on Linux Foundation Public Health. I've been working with WHO and other UN agencies as well as governments.
Oh.
So one of the big area we're focusing on is trust infrastructure. So that's probably what Gang is looking into as well. So we're actually looking at how, so interoperability, there are different levels, right? You're talking a lot about like the health content and also the data level, but also you touch upon the trust level, which is like something that I know like the WHO is leading some work, and also there's a government G20 like pretty involved in that conversation, as well as other regional kind of government networks who are looking into it. But the work I'm doing pretty much how we can bring kind of different kind of
It's interoperable.
together so they can have their flexibilities of making their own rules. Actually, Tafka was mentioned.
Well, and you have quite a challenge because there's like 197 countries and they're all differing. And in the United States, policy rules in the state can trump what happens in the federal level. And I think a really important difference is under the HIPAA, when the promise of a patient being able to get their information, when they receive that information, they go from being patient to being a consumer. And the privacy protections on the consumer are very, very slight. They can only be prosecuted if they do something that is not said in their privacy thing, what is it, privacy, I forget what they call it. But everybody has to have one, so.
It's quite complicated, and the conversation I'm involved in is more about how governments at that level can trust each other, even to understand what each other's policies are. Because when it comes
We should map.
verifying vaccine credentials, right? Because you can't just take their public keys and then just verify it. You have to understand what actually you're taking in, and also like what is the kind of a privacy, even the user level, right? If I have a vaccine, I come from Canada, right? Come to US.
And what are the requirements?
Right, and what kind of information US is accessing, and if I need to know that. There's a lot of that kind of level conversation that's happening, global level, and WHO is trying to facilitate that, but it's really, really hard. And to a question, who is actually going to manage it? If there's a network, right? Who is actually operating it and governing it? This is something like at least.
Okay. I didn't think I'd make it through. Usually my slides are done in 5 minutes and I'm done. Thank you for listening and have a wonderful evening.